Good morning, everyone. Welcome to the Orlando GI Journal Club for August 2025. I hope everyone's doing well this morning. This is our first study is the randomized trial from China, published in the Red Journal, looking at adding linaclotide to a polyethylene glycol bowel prep for colonoscopy. So as everyone is already aware, inadequate bowel preparation is a major issue during colonoscopy. And polyethylene glycol is most widely used laxative for bowel preparation. But the high fluid intake is still a problem. Linaclotide is FDA approved for treatment of constipation predominant IBS and for chronic idiopathic constipation. And so the aim of this study was to investigate the dosage and timing of linaclotide capsules in combination with polyethylene glycol for bowel preparation. This was a multicenter randomized trial conducted in China at 16 centers. This was a non-inferiority trial. What they did was patients presenting to outpatient setting for a screening, surveillance, or diagnostic colonoscopy were randomized into 3 groups. Group A received linaclotide for 3 days and then 3 liters of polyethylene glycol. In China, they use 3 liters, not 4 liters, which is what we use here of polyethylene glycol. And they compared that to 3 liters of polyethylene glycol alone, or the third group was linaclotide for 3 days and then 2 liters of PEG. Now, everybody received split dose preparation, which, as you already know, is superior to just taking it one sitting. And the non-inferiority margin was set at 5%. All colonoscopists were blinded to the type of preparation that the patient received. The colonoscopies were videotaped and they were sent to a central system in Shanghai, where the videos were assessed by 2 assessors who were blinded to the group allocation. And the primary outcome was to compare the adequacy of bowel preparation rated using the Boston Bowel Preparation Scale, and the adequacy of bowel preparation was rated at score of at least 2 for all colon segments. So they had 535 patients in the linaclotide plus 3 liters group. 537 patients were enrolled in the just 3 liters of laxative group. And then group C, 535 patients were enrolled in the linaclotide and the 2 liters of PG group. In terms of kind of the baseline characteristics, they were pretty similar, as you would expect in a randomized trial across the 3 groups. This is China, so as you can tell, the body mass indexes are pretty low. Everyone, the median and mean both being less than 25, interquartile range ranging from 20 to 25. The indication for colonoscopies were screening colonoscopies in around 33% of patients, diagnostic colonoscopy in around 54% of the patients, and surveillance colonoscopy in 12 to 13% of the patients. So when looking at the primary outcome of the adequacy of bowel preparation, in the linaclotide plus 3 liters of PG group, adequate bowel preparation was found in 88.8%. In the 3 liters of polyethylene glycol group only, adequate bowel preparation was found in 83.99% of the patients. In the linaclotide with 2 liters of PG group, adequate bowel preparation was found in 87.9% of the patients. When they compared the linaclotide plus 2 liters, so lower volume of PEG, with the linaclotide plus 3 liters of PEG, so higher volume, they found the risk difference, the rate difference of 0.93%, with 1 to 5% confidence interval of minus 4.8 to 2.9. And so this shows you that linaclotide plus the lower volume PEG is non-inferior to linaclotide plus the high volume PEG. When comparing linaclotide plus lower volume PEG with just PEG bowel prep on its own, the rate of adequate bowel preparation difference in the rate of adequate bowel preparation was 3.87%, with 95% confidence interval of minus 0.3 to 8. So this also shows that linaclotide plus 2 liter is non-inferior to just polyethylene glycol alone. And these are the results for the intention to treat analysis. When looking at the secondary outcome measures, there was no significant difference across the board for polyp detection rate, adenoma detection rate, cecal intubation rate, the time taken to get to the cecum, withdrawal time, but if you look at the p-value comparing the 3 different groups in total, subject satisfaction was highest in the linaclotide group, and the both 3 liters and 2 liters compared to just the high volume PEG group alone, which is a little surprising. Okay, yeah. Next, when looking at the adverse events, the overall adverse event rate was 13.6% in the linaclotide plus 3 liters of PEG group, 9.7% in the PEG alone group, and 8.8% in the linaclotide plus 2 liter group. If you compare the difference overall between the 3 groups, as you can see, the p-value is 0.024. So it looks like the overall adverse event rate was the lowest, and significantly so for the linaclotide plus the lower PEG volume. But as you can see, severe diarrhea was reported in the linaclotide group, but none in the just PEG alone group. Bloating, surprisingly, was encountered at a higher rate, although not statistically significantly so in just the PEG group alone. Abdominal pain was reported ranging from 0.9 to 1.5% across the board, with no significant difference between the 3 groups, and the same with a rate of discontinuation because of abdominal pain, and the rate of abdominal pain because of the bowel prep. If you look at the rate of nausea and vomiting, however, it was the highest in just the PEG group alone, followed then by linaclotide plus the lower PEG volume, and then the lowest reported in the linaclotide with the higher 3 liter PEG volume. And the significant p-value is seen when you compare Group B and Group A, Group B and Group C. Group B and Group C, and Group A and Group C. So the limitation of this study is that they excluded from this trial patients with constipation, obesity, irregular bowel habits, and therefore the results of this study are applicable only to average risk population for bowel preparation. And as noted before, in China, 3 liters of PEG is used rather than 4 liters, which is used here in the United States. So the take-home point from this randomized trial is that the bowel preparation of adding linaclotide to a lower volume PEG taken as split dose preparation was non-inferior to linaclotide plus 3 liters PEG, or there was a typo, with 3 liter PEG or 3 liter PEG alone in an average risk population when undergoing either screening, surveillance, or diagnostic colonoscopy. Next is a study published in Gastroenterology. This is by Toyoshima et al., looking at the texture and color enhancement imaging observation in the detection of colorectal lesions, conducted in Japan. This is using the new TXI feature in the newer Olympus colonoscopes. Image-enhanced endoscopy has been reported to improve adenoma detection rate and the mean number of adenomas detected per procedure. The EVIS X1 endoscopy system, manufactured by Olympus, features the novel TXI mode, which is designed to enhance 3 image factors in white light imaging: the texture, brightness, and color. So what these authors wanted to do was compare the mean adenoma detection rate between TXI and white light imaging during colonoscopy. This was a multi-center randomized trial conducted at 8 centers in Japan. This was a superiority trial. They included patients aged 40 to 80 years who were scheduled to undergo screening colonoscopy, surveillance colonoscopy, or those who had symptoms or positive fecal occult blood test and therefore undergoing diagnostic colonoscopies. They used the latest model colonoscopes only, and patients randomized in a 1-to-1 ratio to undergo colonoscopy using either TXI in mode 1 or white light imaging, and the primary outcome was the mean number of adenomas detected per procedure. 451 patients were randomized to the TXI arm, and 445 patients were randomized to the white light imaging arm. The mean age was 64 years in both groups. There were more men than women enrolled in the trial, 64% versus 36%. The most common reason for undergoing colonoscopy in this trial was post-polypectomy surveillance at 48%, followed by colorectal cancer screening at 33 to 34%, followed by positive fecal immunochemical testing at 12%, and GI symptoms of around 5%. The endoscopist expertise were consideed experts in 68%, in the TXI arm, 66.5% in the white light arm. Withdrawal time was mean of 10.3 minutes in TXI arm, 9.9 minutes in the white light arm. A transparent hood or a distal cap was used in 88% in the TXI arm and 89% in the white light arm. The characteristics of neoplastic lesions detected and removed, if there were polyps in this, removed or biopsied in the study. Total number of lesions detected was 642 in the TXI arm, 690 in the white light imaging arm. In terms of the location of the lesions, most commonly found in ascending and transverse colon, followed by sigmoid colon, and then cecum. The majority of polyps detected were 5 millimeters or smaller in size, 73% in TXI, 73% in the white light arm. In terms of pathology, 98% of the polyps detected were tubular adenomas, followed by tubular villus adenomas, traditional serrated adenomas in 0.8% in TXI arm, 1% in the white light arm, and then cancer was detected in 1.1% in the TXI arm and 1.5% in the white light arm. So looking at the outcome measures, So the primary outcome was the mean number of adenomas detected per patient. The mean was 1.4 in the TXI arm, with standard deviation of 2.2. In the white light group, it was 1.5 mean and standard deviation was 2.2. The mean difference is minus 0.1%. With a 95% confidence interval for difference of minus 0.4 to 0.2. And because this 95% confidence interval spans 0, you would expect the p-value to be non-significant, which is the case here, 0.409. When looking at other features of polyp detection rate, so this is adenoma detection rate, overall polyp detection rate, that's PDR, SDR is sess-ulcerated adenoma detection rate. FDR was, flat polyp detection rate. So as you can see, if you look at adenoma detection rate, there's no significant difference between the two groups. But if you look at the overall polyp detection rate and the flat polyp detection rate, you do find that the detection rate was significantly higher in the TXI arm at for polyp detection rate of 82.5% in TXI versus 74% in white light. And again, for flat polyp detection, it was 76.5% in TXI versus 70% in white light. So the limitation of the study was that it was conducted in high volume centers in Japan with high proportion of physicians who are considered experts in the field, which may limit the generalizability of the study results. Again, blinding was not possible by endoscopists performing the procedure due to the differences in imaging modality. The authors report that many diminutive polyps were found, and the pathology actually then showed normal mucosa, but they feel that this is because the polyps were so small that preparation of appropriate cross-sectional histopathological sides were challenging, and therefore they did not actually they were actually not able to obtain accurate pathological diagnosis, which may have then led to underdiagnosis of neoplastic lesions. And lastly, they did not have a central pathology center, as it were, or headquarter to review all the pathology and biopsy and polyp removal, all the polyps removed, and therefore there is likely variability in pathologist diagnosis among institutions, which may have affected the study results. So the take-home point from this randomized trial is that, unfortunately, TXI did not demonstrate superiority over white light in detecting neoplastic lesions, because there was no difference between these two imaging modalities in terms of the number of adenoma detected per patient or adenoma detection rate. But TXI appears to be more effective in detecting flat polyps, which are traditionally very difficult to detect. For Journal Club recap, the adequacy of bowel preparation rate of 3-day linaclotide plus 2 liters of PEG was neither non-inferior to 3-day linaclotide plus 3 liters of PEG, nor 3 liters of PEG alone in average risk population. The study also, our next study, showed that there was no superiority of TXI over white light in detecting neoplastic lesions. However, TXI may be more effective in detecting flat polyps. We're working really hard to prepare for Florida Live EOS, which will be held in Orlando, Florida from August 21st to 23, 2025. There is still time to register. We welcome everyone to come and join us, and it will just be a wonderful educational event. Our next monthly GI Journal Club is on September 3rd, 2025. Thank you so much for joining us this morning. I hope everyone has a wonderful day and week, month, and look forward to seeing you next month. And please come to Florida Live EUS.